A very, very good morning to everybody. I think I'll stick out like a sore thumb in this phakic lens session. I'll be talking about an IOL, but maybe a little bit of leaf from my seniors and stalwarts in this. I remember 1999, Dr. Mahipal did the first ICL, and I, like a trailblazer, followed him, and I did my next one after him, and I've never been looking back. Just 4 points from the previous session are, for people who don't have fancy equipment like IOL Masters or Cirrus or Pentacam, your good autorefractokeratometer with good imaging system can serve very well. I probably have the highest volume of phakic lenses in this part of the world, 6,000 plus. And I have patients operating in 18 of my centers. Not all have these equipments, and we are doing very well. So basic point is have an autorefractokeratometer, use the pupillary marker, and have two optometrists do an independent data. Don't let anybody look at each other's data, and you'll get a fairly very accurate. For my practice, I use a caliper only to confirm, not as the primary. Number two, when you're operating a keratoconus patient, this can be very, very tricky. Look for an angle more than 45, in case you're planning a high vault. When you're doing a toric patient, plan a higher vault, because if this lens rotates, you could be in trouble. A monofocal lens, if it rotates, doesn't matter. If your lens has rotated more than 30 degrees, explant it. No use redialing it again, it'll again rotate. So little practical points. Now coming to my topic. So I'll be talking about the EDOFs. I am a fan of EDOFs. I was probably one of the highest multifocal users in this part of the world. I've switched nearly 100% to EDOF lenses. This is one of the current lenses which I use. I have no financial relationship here. Is it the holy grail? Presbyopia correction after cataract surgery, is it the holy grail? And are the EDOF lenses the missing link of correcting presbyopia? And I call it iatrogenic presbyopia, because it's the doctor, actually, especially in a myopic patient, who's creating the presbyopia. The patient didn't have a presbyopia before that. So are EDOFs so we'll be looking at a lot of it. This could actually be this is a part of my instruction course. I'm cutting the slides. For people, beginners who want to move into phakic IOL practice, I have an instruction course tomorrow at Kamal Hall, 2:45, how to start a phakic IOL practice for beginners if you don't have a fancy machine equipment. So you have 4 kinds of presbyopic correcting lenses: multifocal lenses, enhanced monofocals, EDOFs, pinhole lenses, and accommodative lenses. Basic principles are the diffraction, refraction, and pinhole. These are the 3 principles most of these lenses will work on. Either it will be a combination of them or one of them. So multifocals, we know, create a discrete point of focus, and there is a zone of defocus. So that is a big problem with multifocals, at least in my practice. I was doing 200, 250 plus multifocals a month, but the chair time was eating my head, because the amount of chair time I had to spend with the patient before. Otherwise, I was spending 10 times more after the surgery. So I was looking for an alternative which would probably give me a free hand and able to do more and more, the lens being more versatile. So this is how a monofocal lens will be actually. Can I have a pointer, please? Okay, let's work with this. A monofocal will have a single point of focus, a diffractive bifocal will have 2 points of focus, and a trifocal will have 3 points of focus. How do EDOFs work? EDOFs actually work by creating a long tunnel of field of vision. They do not have a single point focus, but they have a diffuse point of focus stretched over a little distance. So when the patient tries to bring the object closer, they'll raise the more diffractive, and the negatively spherical aberrated lens actually creates that tunnel of focus and defocus. So patients have excellent intermediate vision. The only issue with the EDOF was it was not giving you a good near vision. But let's face it, in our day-to-day lives, our mobile phones, our laptops, eating food is intermediate. Gone are the days when you're lying down and reading a book. Until unless you're hiding your chat from your wife and working on the phone like that, or your husband. So we're not using the phone so close now. So what an EDOF does is it creates a longer zone of focus. It's like a funnel. It funnels the light and gives you a longer travel distance. And the American National Standard Institute actually has given a very vague definition of EDOF. There's still not a very standard definition. What it says is more than 50% of your patients should be N9 or better with full distance correction. So the lens should be having a little bit of myopic shift of more than 0.5, but it should not be underperforming for distance than a monofocal lens. But if you actually look at the definition, it's a very broad definition. So I have used, so this is what a monofocal lens will have an energy distribution in the center. A bifocal or a trifocal will have bumps. You'll have energy distribution in the MTF curve, then one for intermediate, and one for distance, and one for near. What an EDOF does is, it gives you a clear focus for the distance, and as you start getting the object near, you have a longer defocus energy distribution. So you are able to see objects. Why did I stop using multifocals? First of all, the patient is not happy till you operated the second eye. The multifocals are very, very intolerant to residual astigmatism. Capsular opacification, even a slight amount of capsular opacification in multifocal can really trouble the patient. Loss of contrast in multifocals is far more damaging than the EDOF or your monofocal lenses. If the patient, God forbid, has a macular edema, multifocal lens, the patient is probably going to shoot you. Any amount of surface disorder is more unforgiving with a multifocal than with an EDOF. So these are the reasons why I actually started moving away from multifocals. In my practice, most of my lenses, multifocals are being implanted in the patient where I've done a multifocal earlier, and he was happy. Otherwise, I'm not. So multifocals are very, very intolerant to bad pupil sizes, and of course, more chair time. So these are the 8 C's why I'm shifting away from multifocals. The reasons for explantation of multifocals are, the literature is full of them. Most of them are photopic phenomenon, halos, glares, loss of contrast. The literature is full why people are explanting the multifocal lenses. Now let's give you a basic understanding. How does a lens EDOF work? In a positive spherical aberration, the peripheral light rays are focusing in front of the macula. In a negative spherical aberration, they're slightly further away. If you slightly start increasing the negative spherical aberration, you start getting a longer tunnel of focus. So this is the basic concept. So this is called a zone of defocus, but yet there is a lot of light there. But there is a catch here. You cannot indefinitely increase the spherical aberration because then it will start causing a bigger defocus. This is what happens. So most of these lenses will work best for 2+2 diopters of depth. The moment you start going more, you'll have a broader defocus zone, and this will happen. This ring will start getting bigger. So your loss of light is higher. This can large pupil size, you'll have peripheral distortions. This is a photograph I took out of the fisheye lens. So understanding types of technologies, I'll just spend little time there because this slide actually includes Vivity, your Lucidus, Siphi. I've used all these lenses. But I'm just skipping it. So these are broad categories of lenses, which are types of lenses. Some of them are hybrid, some of them are pure EDOF, some of them are enhanced monofocal lenses. Energy distribution, as I did explain, EDOF has a longer energy distribution, so the loss of contrast is less. You have more depth, but yes, it will not work for near. I've done more than 6,000 of these magnification lenses. I'm fairly satisfied. I'll just share my data. 68% of my patients are N9 or better, and they say they don't need glasses at any point of the day in their day-to-day routine, which is far better than the 50% data recommended by the American Society. So 6 by 6 and N by 6, 68% were in the standard deviation main curve. Least amount of photic phenomenon and glares reported with the enhanced monofocal category. This is how the lens probably works. Central 3 mm zone is giving you a near add of 1.75, which is a fairly good distance appreciation. Preoperative chair time, you need to tell the patient that you are not going to see very good for near. You need to emphasize that because patients will always listen that you're referring to near, but you're referring to intermediate. So what I do is when I explain it to the patient, I do the hand action. The lens will work at this distance. So I make the patient repeat. How far will the lens work? So once they've actually memorized it, they will not come back to you and complain, oh, it doesn't work here, because you made them enact the whole thing. So first question I ask the patient is near vision more important to you, or can you live with glare and halos and not being able to drive at night? Guess what? 92% patient says, I'm happy with intermediate, I don't want glares. That settles the matter for you. This patient is never going to complain for a bad near vision. So most are okay.